Now, tumors of the bladder most commonly are primary tumors, but there are metastatic tumors that can come to the bladder also. This is an unusual case of a patient with colon cancer where this frond-like mass in the wall of the bladder is actually a metastatic disease to the bladder. And you can see it here again. This is the top of the bladder here. It's a little bit irregular, thickened, and there's a mass coming out of the bladder as well. So this was metastatic cancer to the bladder. Another patient with a bladder and sagittal view, you can see here a focal mass at the top of the bladder, and when you turn it transverse, this is that same focal mass, has a very interesting straight line going through it, and it turns out that this is a site of a surgical suture, and so this is a focal surgical scar in the bladder, which presents now here with a mass. Much less common reason for mass in the bladder. So just to review what we've seen so far, bladder masses, we've seen stones causing mass, we've seen clots as a cause for a tumor, focal space occupying lesion in the bladder, and then you have tumor and scar. And this is just another case. Here we see the bladder, and here we see mass filling up much of the bladder. This turns out to be advanced transitional cell carcinoma growing into the bladder. So we're finished basically with the section that I wanted to talk to you about bladder. We're going to move on now to discussing the scrotum and the structures within the scrotum, which is primarily a discussion of the testicles. So the normal testicle is an ovoid shaped structure. It's very well defined and has a very smooth contour because it is surrounded by a tunica. The testicle itself has a thick tunica albuginea, and then it sits inside this tunica vaginalis, which surrounds it laterally and anteriorly. You see the testicle in long axis is about 3 to 5 centimeters long, and this is the short axis of the testicle, usually 2 to 4 centimeters. And this line coming through here, that corresponds to the mediastinum testis, which we'll talk about in just a second. Very important, whenever you evaluate testicles, try to obtain an image where both the right and left testicle are seen at the same image, at the same depth, and you can compare the echogenicity of the two testicles. This view goes right through the midline raphe that separates testicles. There should be a symmetric appearance with homogeneous echogenicity. To understand some of the ultrasonic anatomy of the testicle, it's important for us first to look at some of the anatomy that's inside that testicle. The testicle really is an amazing structure. There are hundreds and hundreds of thousands of these seminiferous tubules that are coiled up inside the testicle. Now they're all wrapped in this very thick tunica albuginea, and a tunica albuginea has these radiating septa which separate the testis into somewhere between 250 and 400 separate lobules. Okay, each one of these lobules then contributes a duct that goes into what's called the redae testis. The redae testis is this network of ducts that come out of the seminiferous tubules and go through a portion of the testis, which is called the mediastinum testis. These tubules then join to form somewhere between 10 and 15 efferent ductules, which exit the testis and join into the epididymis. The epididymis, once again, is basically a big piece of spaghetti with multiple tubules that are coiled up and finally come through the epididymis and end at the tail of the epididymis in a single efferent duct, which becomes your ductus deferens or the vas deferens. And so there's spermatogenesis going on in the testicle, and these spermatozoa come out through the redae testis, they go into the epididymis, and finally through the epididymis into the vas deferens. As I mentioned before, when you look at the testicle ultrasonographically, you will see that there is a straight line going through the center of the testis, and that's called the mediastinum testis. And that linear appearance results from the convergence of these ducts into a sort of a plane in the testis, and these efferent ductules then come out of that mediastinum testis and go in from the mediastinum testis into the epididymis. Now the epididymis has anatomy which is generally described as a head, a body, and a tail. So the head corresponds to the thickest part of the epididymis, which is usually not more than a centimeter, maximum a centimeter and a half in diameter. And as you go down the epididymis through the body and tail, it progressively tapers. The epididymis itself should be isoechoic to the testicle, or perhaps slightly more echogenic. So here we see the head of the epididymis, the body of the epididymis, and a sagittal view showing you the long axis with the tail of the epididymis down here, easily seen because there's a small amount of fluid or hydrocele within the scrotum. Now, in addition to the epididymis sitting outside the testis, there's also two other structures which you should be aware of, the appendix testis and the appendix epididymis. These are both embryological remnants. They are found towards the upper pole of the testis, and they may look like just small little nodular excrescences coming off the testis. These are normal. They can actually detach from the testis and may result in what we'll call later a scrotal pearl. So a scrotal pearl is a calcification. It's seen within the layers of the tunica vaginalis. It's a little bit controversial as to whether this actually does represent a remnant of the appendix testis or the appendix epididymis that is torsed and is broken off, or whether it represents the result of an inflammatory process in the tunica. In any event, scrotal pearls are often associated with hydroceles, and usually they're mobile, little calcified structures. The important thing to understand is that these are benign findings, and it's a leave me alone kind of finding. So if you see a calcified mobile structure outside the testicle, that's something that's a benign structure. Don't worry about it. We talked about in the anatomy of the testis that the mediastinum testis contains this network of tubules, the vitae testis. The vitae testis can become dilated, and that's what you're seeing here. Multiple dilated tubules. They're parallel tubules in the mediastinum. It's important not to confuse these with a mass. So often they're bilateral. Here's the midline view through the raphe, left testicle, right testicle, dilated vitae testis on the left, dilated vitae testis on the right. Do not mistake this for a mass. The way to tell them apart is the characteristic location, and if you use the proper angle, you can see that these will elongate into tubules. Here's another patient. This is the mediastinum testis, and we see the dilated vitae testis here. Dilated vitae testis, by the way, are often associated with cysts within the epididymis. Let's talk a little bit about Doppler flow now within the testis. So the normal testis does have flow, and it should be relatively symmetric flow in the two testes, and it should be a normal branching pattern within each testis where the branches run parallel to each other. And so here you're seeing the normal branching pattern within a testis, and a midline raphe view showing you relatively symmetric flow in the two testes, and very, very little flow is generally seen in the epididymis. Another thing that we need to consider is fluid within the scrotum. So often when there's a dilated scrotum, the question is there a mass there or is it fluid? Often the reason is just a simple hydrocele, but you need to be careful because hydroceles can be associated with masses. What is a hydrocele? Remember we talked about the fact that the testis was wrapped in the tunica vaginalis. The testis actually invaginates into the tunica so that the tunica covers it laterally and anteriorly, but not posteriorly. So there's tunica vaginalis coming down here, coming around the testis, and coming back around the scrotum here. Within the layers of the tunica vaginalis is where the hydrocele exists. So there's fluid surrounding the testis on lateral aspects, superiorly, inferiorly, and anteriorly, but not posteriorly. The testis is attached to the scrotum posteriorly, and there should not be hydrocele there. Okay? Congenital hydroceles may be related to incomplete closure of the processus vaginalis. So there's fluid coming down through the inguinal canal. Usually these resolve by 18 months. Acquired hydroceles are most commonly idiopathic, but they can be associated with infections, infarctions, and trauma. And obviously, if there's a mass in the testicle or mass in the scrotum, you need to worry about that as a cause of hydrocele. And testicular torsion also can be associated with fluid as a hydrocele.